Hello, this is Professor David Bishai, and this is part 3 of our lecture on the demand for health. And in this part of the lecture, we're going to cover in detail some of the implications of the Grossman model and some critiques of the model that help us understand how to use it and apply it for insight into the health economy. First critique of the Grossman model is that it is unabashedly a model of how individuals produce health. It is a micro model of individual demanders and producers of health, and it really doesn't help immediately tell policymakers what to do to help these individual producers make themselves healthy, nor does it offer the policymaker any idea about how policies about air and water, about infectious disease control could affect health. If you think about the 2020 epidemic of COVID-19, each individual agent trying to stop themselves from getting sick from COVID-19 has a lot of things that they can do as individuals. They can wear masks and they can socially distance and wash their hands. However, individuals who lived through the epidemic know that there was a lot that other people could do to help control the risk of COVID-19. The governments of the world could initiate policies that made thousands of neighbors wear masks and socially distance. And that's not covered in the Grossman model. In the Grossman model, the only thing you can do is protect yourself, and there's really no production model of how other people can create public health policy that would protect you. So if we wanted to extend the Grossman model in this direction, it would be useful to think about using a formula like this one, where the health at time t, certainly it has its depreciation as before, but if we wanted to increment it, we could increment it both with individual medical care, but also with public health capital. This would be what commissioners of health and governors and presidents might do in order to help produce the health of everybody's body. This is the idea that you are not alone in your desire to produce health. If we were to draw a picture of what this model might look like, then there would be two ways to climb this health mountain. If we look on the vertical axis here, there would be a measure of health capital for the individuals in society. This would be the zero of the health mountain, and this would be a high value of the health mountain up above 10. The inputs come from a zero over here, and one can, as before, put in private health inputs, this medical care and doctor visit input along this private health input axis, going from 20 to 100. And as we put in those private health inputs, you can see the elevation of the mountain gets higher and higher because investing in private healthcare inputs is effective at creating health. However, we can also climb the mountain by going in this direction up the public health input axis, and as we invest inputs in the public health input axis, we can climb the mountain as well. So both ways could help us climb the mountain. Another implication of the Grossman model has to do with the assumption of rational choice. In this model, the demand for medical care really does include the demand for medical advice. So the idea that there's information asymmetry could be perhaps overcome by purchasing the advice from medical professionals. However, at the end, it's up to the individual to be fully rational and to apply these recommendations from professionals appropriately. And if we do presume complete rationality and use a Grossman model to derive an input demand function, or how much pills and doctor visits should I actually purchase, many people want to interpret demand curves as marginal utility curves. So let's go back to this point that a demand curve is really a marginal utility curve. And we're going to do that by looking at a demand curve where the assumption of rationality is a lot more believable. Let's look at the demand for fruit. Now suppose you lived in a world where there were only two kinds of fruit. There were tangerines and lemons. and they cost exactly the same price per pound, but there's a way to get a discount on the lemons. Now, you hate lemons, but you can use them for compost, and you're willing to pay $10 for 10 tangerines. You're willing to pay $1 per tangerine, but you only want 10. You don't want 11. You don't want 9. You want 10 tangerines. You're willing to pay $1 for 10 lemons, or 10 cents per lemon, but you only want 10 lemons. So you have this discontinuous demand function that looks kind of like what's shown in this next graph. So this is the demand curve for fruit, and if the price per lemon is $1, price per fruit is $1, you'll buy 10 tangerines, but you need a discount. You need somebody to mark down your price of fruit to 10 cents in order to want to buy lemons. So if you were looking at this demand curve and you had insurance that would allow you to see a price of only 10 cents per fruit, you would buy 10 tangerines and 10 lemons. So if the price of fruit goes down to some copay times the marginal cost, you would buy this mix of the fruit you really like, the tangerines, and the fruit you don't like so much, the lemons. And if we send the price back up to the full marginal cost, we no longer give you the discount, you would give up the lemons and you would only buy tangerines. And in this sense, we are seeing from the demand curve a lot about your marginal utility, that you get higher marginal utility from tangerines and lower marginal utility from lemons. And so the demand curve is expressing the facts about your. The question here is a healthcare demand curve really a marginal utility curve? Let's apply our fruit analogy to healthcare. Supposing you lived in a world where there were two kinds of healthcare: the high value, really life-saving healthcare, and low value healthcare, which is kind of optional. It's makes you a little bit healthier, but it's not as important as the high value care. Now, if they cost exactly the same price per encounter, you might need a discount to want to buy the low-value healthcare. If this were the price of healthcare encounters versus this price and then this price, over here at the very low price, discounted by insurance, we might see you using a mix of high and low-value care. What would happen if we took away the discount, took away your insurance? The prediction, tested by Kathleen Lohr, was that as we lifted away insurance, one would revert back to using only the high-value care, only the tangerines. So that's what she predicted. Drawing this again, this is a figure drawn from the Rice and Unruh textbook that you can see on page 114. The implications would be a rational consumer who's fully insured would consume Q0. If they were fully insured, they would consume all the way as far as they possibly could until price was zero. And then if uninsured, they would consume Q1, they would consume less care. And if you've seen some of the results of the RAND experiment, you know that this actually happened. People consumed less medical care when they were uninsured. However, the prediction of the rational maximizing model of Grossman is that the bundle in Q1 would include more highly effective health care than the bundle of things consumed when fully insured. So the experiment that we could run is to ask whether removing health insurance changes the care pattern. So similar to the tangerines and lemons, we say that there are red pills, which are highly effective, and there are blue pills, which are not as effective, and then there's other stuff, call it orange pills. So the prediction of the model would be that if you are an insured Grossman maximizer, you would consume 120 pills all the way out here. There'd be 60 of these red pills, 30 of the blue pills, and 30 of these other orange pills. However, we take away your insurance. The model predicts that you won't buy any more of these blue pills, and you'll only buy the red pills. So if we take away your insurance, you might not consume here. You might only consume the 60 red pills, even though this is where the price intersects the demand curve. Well, so what did the data say? Here's what Kathleen Lohr found. She found that as coinsurance went up in the RAND experiment, people gave up both the high value and the low value services. They were not supposed to give up the high value according to the prediction. So if we really want to interpret demand curves as marginal utility curves, we've got a problem. Now, the obvious explanation is that there's information asymmetry, and that just never goes away, even though somebody can purchase medical advice. What we now think of in light of these findings is that downsloping relationship between price and quantity is just a downsloping relationship between price and quantity. What we found in the Rand experiment, that as price goes up, people consume less, that's just a relationship, but it really should not be interpreted as a marginal utility relationship. So this calls into question the theory of the individual as a rational producer of health out of health services, simply because they are not sufficiently informed about the health production function. And even when they can buy advice or Google health advice on the internet, they're still not able to make rational. The evidence in more detail, what did Kathleen Lohr find? She found that in the Rand experiment, children in the upper middle income groups who were assigned to co-insurance used 85% as much highly effective care as the free plans. So the highly effective care given to the children went down when they had to pay co-insurance compared to free. And furthermore, the reductions in care were equivalent in both for both low effective and high effective care. And remember, when we looked at what happened to the health in the Rand experiment, summary measures of health using this tool called the short form 30, just 30 questions that ask how healthy you were, not affected by insurance status. The only measurable health impacts of having insurance were that the free care group had a tiny bit of improvement in the control of their blood pressure, and they had better vision correction. So there's no evidence from the Rand experiment that what insurance was doing was giving people lots more better, highly effective health care. It was probably giving them some mix of high effective and low effective, and so the health impact was diminished. So why do we care about this finding that demand curves are possibly not marginal utility curves? Well, in the first case, if the healthcare demand curves really were marginal utility curve, then what we were saying about in the economics of health insurance was that there's this big deadweight loss from moral hazard as people consume all of this extra healthcare. The area between the demand curve and the marginal cost was this loss to society. And so we need co-insurance to control a real problem. This is a very firm belief of many American health economists that comes into question, because that downsloping demand curve in that model might not really be a measure of utility. It's just a relationship. So if healthcare demand curves are just a loose relationship between price and quantity, then that's not really a measure of social welfare. It's not measuring social welfare. It's measuring something else. So the other thing we do see is that because people who have to pay a copay, and the higher the copay or deductible, the more they give up stuff, they're actually giving up highly effective and low effective care. So coinsurance rates can hurt people who give up life-saving treatment because they don't know better. And that type of damage is not covered in that model of moral hazard. That people who give up the highly effective care could actually forego very, very important health benefits. I want to move on to another implication of the Grossman model, which is a concern for health equity is something that makes us want to do policies to help the poor and help create equal health outcomes between the rich and the poor. Now, once we've started with the Grossman model, we see this implication that schooling and wages are fundamental bedrock reasons why demand for healthcare is what it is. And if someone has low schooling or low wages, that is a rock bottom reason for low health demand. So if that's true, then the world looks like this graph on the right, where there is a demand of low wage workers to the left and a demand for health of high-wage workers on the right. So if we are going to use healthcare insurance by dropping this supply curve of healthcare, this horizontal line, the price of someone's uninsured, if we drop that down, well, back down here, the quantity demanded at a price of 0 of the low-wage worker is still lower than the quantity demanded of the high-wage worker. And the lower the price, it doesn't narrow the gap of utilization between the low-wage and the high-wage worker. They remain this far apart if they pay full price, and they remain far apart down at price of 0. So health insurance cannot fix inequalities in the fundamental difference in the position of the demand curve on the price quantity axis. There's this thing that pricing won't fix it, that free care does not narrow gradients. We'll come back to this prediction in about later in the course. So health equity seems fundamental in the nature of what makes somebody want to be healthy, and poverty, if we believe the model, is a fundamental problem. So if we believe this, how would we pursue health equity between the poor and the rich? Well, for that, you would not appeal to the demand curve. You would invest in things outside of the micro individual's control. You would apply public health measures that make all people healthy regardless of their demand for health. If you make people healthy by universally cleaning their water, their air, their roads, their food, if you universally protect people by making an infectious disease epidemic just not have as many infected people coughing on you no matter where you go, then we escape that lower demand for health of those who are less educated or poor. That would be the policy proposal, not drop the price to 0. It's a fundamental change in policy. The ACA, if it was pitched as a way to help poor people become more healthy, was a little bit misguided according to this light. The Democratic liberals who wanted to help the poor back in 2010 when they passed the Affordable Care Act, if they really were thinking of this theory, they would have invested much, much more in public health than in subsidizing the price of health insurance and making it more available. And what we're seeing in 2019, years into the Affordable Care Act, is really not a lot of progress on narrowing inequalities in health. And during 2020, during the coronavirus epidemic, we saw very little differences in exposure and death rates and attack rates of the coronavirus epidemic. So the model has important implications that have not been sufficiently tested or sufficiently recognized. So let's summarize. The demand for health, the model that we propose says that people demand health to get more money out of the labor market because being healthy can make you get paid a higher wage and give you more effective working years. A second reason people demand health is because health just feels good. We have a model that has several important predictions. It predicts that people with more schooling, the schooling will make them want more health, and so they will want more health care. And this is partly because they have higher wages, and partly because they are such good producers that giving them more inputs into health production just you get more out of it because you're more productive at using the inputs. Same with low wages. Low-wage people have a lower demand for health. High-wage people have a higher demand for health. And when we test these predictions A and B, we find that they're both true. Finally, we have a prediction that co-pays, the more you have to pay for your health care, the less you will demand low-value care. And when we looked at the evidence from the Rand experiment, we found that that was not true. That people are not as fully rational when it comes down to producing health, partly because of asymmetric information about what it takes to become healthy. So this is the end of our lecture on the demand for health, and I look forward to discussing these issues further with you. Thank you.